Thank you, Dr. Joffe, for joining me.
Thank you for having me.
So, you wrote a preprint article called COVID-19 Rethinking the Lockdown Groupthink, but originally you were a proponent of lockdowns. What reasons did you first have to support lockdowns, and when did you start reconsidering?
Good question. I just should point out at the start that the preprint is now published in Frontiers in Public Health, so it's a peer-reviewed publication now. Um, Initially, I was in favor of lockdowns, and I think that was for a few reasons. One is being a healthcare worker. I was focused on one disease and one problem only, and that is the SARS coronavirus 2 and COVID. And the initial data coming from China uh, was a bit misleading in that the case fatality rate was around 3%, and if that was truly the case, then that would suggest that we're in for a severe viral pandemic and lockdowns may be warranted. Um, and your next question is what made me change
Start
my mind?
reconsidering. Yep.
Yeah, there were several things that happened. One is more accurate data emerged, and uh, that showed that focus on the case fatality rate is the wrong metric. We should focus on the infection fatality rate. And so case fatality rate talks about the mortality rate in people who have COVID-19 diagnosed and detected. And it turns out that many more patients do not have the virus diagnosed because they are either asymptomatic or very mildly symptomatic. And when antibody studies started to be done in different parts of across different parts of the world, it turns out the infection fatality rate is far lower than the case fatality rate, and it also is very age dependent, which means that overall the uh, infection fatality rate is closer to a median of 0.23%. And in people under 70, the median is 0.05%. And even that's a bit misleading because it varies by age. So in people um, who are young, for example, children, the infection fatality rate is very low. It's lower than 0.001%. And in people under 50, it's lower than the infection fatality rate with influenza. And but people who are 70 and older, it seems that there's an so-called inflection point in the uh, infection fatality rate, and it starts rising steeply. So the really high-risk group is 70 and older, and also 60 to 69-year-olds who have multiple severe comorbidities. And so that suggested to me that those are the groups that we should be focusing on and protecting as opposed to shutting down everyone in society. Um, the other thing that put it a bit in perspective for me is I started looking into how many deaths happen in years without the pandemic. And uh, and you know, in Canada in 2019, so a non-pandemic year, there are over 797 deaths per day, uh, and 291,000 deaths per year. And so we're hearing about, you know, maybe 6% of the deaths that are due to COVID, but we're not hearing about 94 or more percent of deaths that are happening from other causes, some of which are preventable. And the last part that influenced me is that there are so many collateral damage effects of lockdowns, and no one had done a cost benefit analysis. And it seems that to restrict charter freedoms, uh, due diligence is necessary to show that the benefits of lockdowns outweigh their costs. And when I looked into it, I found that actually the costs, so the harms of lockdowns, are far higher than any benefits that they can offer by preventing COVID.
Right. And you wrote an. My next question is like, why didn't anyone in government ask those questions? Why didn't anyone do a CBA at the beginning of the lockdown, looking at the loss of life, who was going to die, what age, loss of life years?
Yeah. Uh, well, one, I don't know for sure that no one did. All I can say is that I haven't seen one, and I don't think there has been one released to the public. Um, and if that is the case, that one was not done, um, I don't have a good answer for you. I think that healthcare workers and doctors are, I think, at least for myself, we are not trained in policy decisions and weighing costs and benefits that are necessary in making those kinds of decisions. And I think the people who are experiencing in that are emergency management experts, and every province has its emergency management organization or agency that coordinates management of public emergencies. And I think uh, that it would have been far better to have emergency management organizations coordinating the effort as opposed to doctors and medical officers of health who have to be involved, but I think are not trained to make the difficult trade-off decisions.
And what do you think led governments to select? This is an argument that David Redman
Yes.
made elsewhere. What do you think led governments to select doctors and health policy or health experts to run our response to the pandemic rather than emergency professionals?
That's a good question, and I honestly do not know. Um, I know that it seems to be the case in uh, most jurisdictions that public health is running the management of the pandemic. And I think that a phenomenon called groupthink may have contributed where uh, people did what everyone else was doing. And in fact, there's a paper that shows that 80% of OECD countries adopted lockdowns within 2 weeks in a period in March. And the strongest predictor of that was whether their neighboring countries were doing the same and not other risks for their population from COVID. So, um, that may have contributed to that decision.
Okay. And so yeah, in section 1.2 you pointed out that epidemiologists are also susceptible to biases and failures of reasoning just like the rest of us. And I noticed in that section you said that they were, or you were quoting a group of people who were looking at the 2009 pandemic, and they pointed out that during that time period epidemiologists all started thinking in worst case scenarios rather than a biased or an impartial risk assessment. Isn't it better to look at worst case scenarios and then reason from that rather than simply estimating what could happen?
Um, well, I don't remember the exact quote you're referring to, but I think the message is one of the messages is that modeling and forecasting to look at worst and best and probable scenarios, at least in the COVID pandemic, it has repeatedly failed. And John Ioannidis and others wrote a paper about that, showing that the modeling has been far off, even in trying to predict next day or in the short term course of the pandemic. And he gives various reasons for that. So yes, I think we do need to look at a spectrum of what expected outcomes could be, but my focus is a bit different. I think it's looking at who is really at high risk and how can we protect them. Uh, so as opposed to locking everyone down, I think the focus needs to be on people who are truly at high risk, and that is the older population.
Right. And so, what would you say to the argument that locking down only elderly people is discriminatory and it's painful for them? Because if you have a year left in your life, you might prefer to give up 6 months of that so that you could spend that with your family rather to live in misery
Right.
by yourself.
Well, there are a few points on that. Right now, everyone is being locked down, including older population. And so even if it was referring just to locking down older people, it would be no different than what they are experiencing now. A second point is that it needs to be voluntary as opposed to mandated by law, which is what we are doing now. And meaning that I agree with you, some people will say, I'm willing to take the risk and I don't want to be locked down. And I think if that is a well-informed decision, that is acceptable. Another point is long-term care homes are a bit different because there are so many, they're a very concentrated population of vulnerable older people. And in long-term care homes, the infection mortality rate can go as high as 25%. So I think that quarantining in long-term care homes is more reasonable than quarantining um, the entire population with lockdowns. And keep in mind that we can improve the facilities where the long-term care homes are quarantined. And that includes having adequate staff, having well-paid staff. Those are necessary reforms even outside the pandemic that are needed, and having adequate facilities for them to be visited either remotely or in person with appropriate precautions and distance. So uh, I wasn't really saying, isolate them individually and, you know, leave them. I think we need to uh, have better options to protect the long-term care homes and options for uh, people who are not in long-term care but are vulnerable because of older age and comorbidities. and have ways to protect them without um, closing down all of society.
And earlier you mentioned that our attempts to model healthcare capacity have failed over and over and over again. And Joanna just wrote a paper about that. Why why have we why have they failed, and what's the alternative that we can be using?
Uh, you know what? I don't know why they have failed. There are many reasons, and uh, people can look at John Ioannidis' paper. It's called Forecasting for COVID-19 Has Failed, and he has tables in there that describe some of the failings and why, but a lot of it is that the input variables uh, are often uncertain, and the assumptions in the model are often uncertain and not well described. And so when a model goes through repeated iterations of contacts and cases and etc., all these small errors can be highly magnified as the model runs to completion. Uh, and that's the way I understand it. Now, I think you're saying what should we use instead of models? Uh,
Right, because governments, as long as we're trying to flatten the curve, governments are, I'm assuming, I'm not a government minister, but I'm assuming that governments are trying to look at when they should impose lockdowns in order to prevent
right.
hospitals from
Uh,
overfilling.
okay, one is uh, that if we protect the older population, the hospital capacity required will be far lower. So that's one point. The second point is we don't even know what the hospital capacity is, um, and including hospital and ICU beds. And uh, I haven't seen that uh, on the government websites for when the number of cases hospitalized in an ICU are reported. We need to see denominators to know what proportion of the capacity that is filling. Uh, because at least some looks suggest that hospital capacity has not been overwhelmed. And it has been stressed at times, but not overwhelmed. Uh, a third point is we need to build a surge capacity, and that needs a written plan uh, and mechanism to do so. And surge capacity should not be uh, based on shutting down all other healthcare. It should be capacity to manage COVID while at the same time continuing with the usual background healthcare for all the other conditions that are equally important. Uh, and I think, you know, there has been talk of being able to surge to, say, in Alberta, to over 1,000 ICU beds, uh, but that has not been required. And if it had been required, that plan would have needed to be implemented. But I come back to the first part is that if we can adequately protect the older population, especially in long-term care homes, that the surge capacity required would be far less, and I do not think we would have been overwhelmed.
Right. Why do you think, if you know this, why do you think for the past 10, 11 months, governments have not been working to increase the number of hospital beds in many provinces around Canada?
I'm not sure. I think some the provinces likely have plans. I mentioned that in Alberta, uh, the premier stated early on that there were plans to be able to increase uh, to over 1,000 ICU beds if needed. So there may be the plans, I don't know. Um, the important thing is that there should be the plans and they should be ready to be implemented if required.
Fair enough. Okay, let's see. You you mentioned earlier the the infection fatality rate versus the case fatality rate, and in your paper you used seroprevalence or serosurveys to find out what the infection fatality rate is. Could you tell us a bit about what they are and what it tells us about our immunity as a society to COVID-19?
Uh, okay, so first, serosurveys mean that uh, blood is taken from a sample from the population and antibodies to the SARS coronavirus 2 are measured. And if antibodies are present, that tells you that the person has been previously or currently infected by the virus. And that compares to when we do a case fatality rate, it's the people who have presented with symptoms or being a contact and have a swab done that by PCR shows evidence of the virus, the SARS coronavirus 2 virus. So antibodies can detect people who never came to healthcare to need nasal swab to diagnose the cause of their symptoms or whether they were an infected contact. So these antibody studies give us a denominator to use in calculating fatality rate, meaning we know how many people have died from and with the virus, and we divide that by the number of people who have been infected by the virus, which we determine by serology. Uh, and many of those surveys have been done. And there are a few review articles about that, but they come to similar conclusions. That the infection fatality rate is far lower than the case fatality rate because around 10 times more people, it varies between studies, but that's a ballpark figure, around 10 times more people are infected than have been detected by nasal swabs. And that's why the infection fatality rate is so much lower than the case fatality rate. And what really tells us about a person's risk from being in contact with the virus is the infection fatality rate.
Got you. And okay, for our, you also mentioned the exit strategy for governments for how we get out of COVID. Everyone agrees that it's going to be herd immunity. Disagreement is whether that'll be caused by vaccines or whether enough of the population will get COVID-19 and then recover from it and they'll be naturally immune. My first question is, how do you know that that is the exit strategy of the government? The thing that I'm imagining is moving forward from now on, every flu season, the government will just reimpose lockdowns in order to prevent their hospital systems from being overwhelmed. In Canada, we've had hallway hospital systems for a very long time. So why would there be an exit strategy? And do you have that in writing anywhere?
Uh, well, uh, I don't have that in writing, but I think everyone is hoping for an exit from all these lockdowns. And I suppose I've assumed that everyone wants an exit. Um, the main reason being that lockdowns have such immense costs in terms of loneliness, unemployment, economic recession, shortened population lifespan, and all sorts of other adverse effects that outweigh their benefits. So I suppose you're right. I've assumed people expect an exit strategy, but that seems to be what is in the literature and what anecdotally I've heard people hoping for, right? So I think that's why I talk about what is the exit strategy, and part of that depends on what is the goal of lockdowns. And uh, you, you know, the goal initially was to so-called flatten the curve so that hospital capacity was not overwhelmed. And now it seems to have shifted to uh, prevent every case of COVID, and one case is too many, and that's not a feasible or, in my view, reasonable goal. Um, but coming back to what uh, may be a reasonable goal, and that is not to overwhelm hospital capacity. Uh, First, I think that lockdowns are not the way to do that. First, there are a few reasons. One is their costs outweigh the benefits. Another is that there are several studies that suggest that their efficacy to flatten the curve is highly exaggerated. And when there are comparisons between countries in how strict their non-pharmaceutical interventions have been, that there many studies find very little effect of lockdowns. Uh, and Now to the herd immunity question. Uh, that's so there seems to be general agreement that in order to decrease lockdowns and open up society, that we need herd immunity. And as you heard, I don't think that is the case. I think better focus protection for older people and planning for surge capacity is a better approach. But let's say that lockdowns were effective and didn't have such immense costs. Then the exit is herd immunity, and that's when enough people have immunity that the virus won't spread. So the R value, the effective R value, number of people infected by one uh, case of the virus, um, is less than 1. And so natural immunity would mean letting enough of the population be infected so that that R value stays less than 1. And uh, recent recent estimates are that that may even occur at 20 to 40% of the population infected. Um, and that is because the highly mobile population with more contacts would be infected first, and those are the main ones you want immune, and that may not require the classical estimate, which would for SARS coronavirus 2 be 60 to 70% of the population. Uh, and the other way is vaccines that induce immunity. And the real way is a combination of the two, right? So uh, vaccines have been developed and are exceedingly important and have been one of the major breakthroughs to control infectious diseases, not just COVID, in the past century. And I'm definitely in favor of vaccines. And I think the more people that can be vaccinated with the new vaccines uh, that are approved for SARS coronavirus 2, the better, because that will contribute to um, reducing people's chance of getting severe cases of COVID. Uh, so I think the exit strategy uh, now is to continue with vaccines and to open up society while still protecting older people until they can all be successfully vaccinated.
Got you. You mentioned earlier how the goalposts have sort of shifted from being from the government trying to flatten the curve to then trying to make sure that there's no COVID in society. Do you know where or if the government, any government in Canada, has published their plan for how they will be responding to COVID-19? Because the JCCF, they published a report saying, well, it's called Flying Blind, where they point out that the government really doesn't have a plan. So has David Redman pointed out similar remarks where they abandoned their pandemic plan written in 2014. Have you seen any literature or plans published by the government?
The short answer is no. Uh, you know, an emergency management process would say that one of the most important parts of the whole um, response is to have a published plan so that everyone knows what the plan is and what their role is and understands uh, what is being done and the rationale for it. Uh, and I agree with that. Um, and to be honest, no, I have not seen an exact plan, meaning when will businesses be open, when would we close, what is the cost benefit balance of lockdowns, and specifically protecting older uh, people in the population, especially in long-term care homes. Uh, so I have to say, it may exist, but I haven't seen it, and I know that David Redman and the Justice Center both have not been able to find it.
I find that worrying. Anyway, you also in your article in your journal publication you had to look for a way to weigh costs and benefits from the pandemic, and instead of settling on a dollar amount, he settled on life years. During this pandemic, we have focused nonstop about lives that have been lost due to COVID, but we haven't looked at the number of life years that we have lost due to lockdowns and compared them to life years lost to COVID. Could you tell us what life years are and how those fit into your cost benefit analysis?
Sure. So to compare strategies, we need a common metric, so a way to measure the costs and benefits. And because lockdowns are a public health policy, uh, we should be able to treat them in the same way as other uh, healthcare policies are um, made. And usually that is by looking at the how an intervention, say for diabetes or heart disease or whatever the illness is, can affect uh, the years of life lost without that intervention. And the years of life lost can be weighted by their quality, and that's what's called quality adjusted life years. Uh, and a better metric is by the uh, well-being of those years, and that's called well-bees or well-being years. And that is a way to measure uh, life satisfaction uh, and everything that affects enjoyment or not of a person's life. So if we use the common metric of uh, well-be years lost, okay, well-being years lost, then we can compare different responses, and we can compare, uh, assuming lockdowns are effective, uh, how many years of life they can save by preventing COVID infections and illness. We can compare that to how many years of life will be expected to be lost because of the costs of lockdowns. And in my cost benefit analysis, I only considered three of the costs, and that is the effect of unemployment on well being, of loneliness on well being, and the effect of the recession. And so I should point out that what using this common metric does is it shows that the often made statement that it's the economy versus lives is a false dichotomy, meaning that it's not the so-called economy versus lives, it's lives lost due to the recession versus lives lost to COVID, and more specifically, years of life lost uh, uh, or well-be's lost due to the recession versus well-be's lost to the um, to COVID without lockdowns. And um, a recession has severe effects on population well-being and uh, life expectancy because the spending uh, government spending is on many of the social determinants of health, and really that determines the population well-being and lifespan in the long term, because government spending on things like uh, healthcare and education and roads, sanitation, housing, nutrition, vaccines, safety, social security nets, and many other things uh, are services that determine population well-being and life expectancy. And there are standard numbers that can be used for how much in government spending will buy uh, how many well-be's or quality adjusted life years, and using and that's what I used in the cost benefit analysis. And so doing that, it turns out that the costs of lockdowns, so assuming that lockdowns are 100% effective in preventing COVID deaths, the costs of lockdowns are still 10 times higher than the benefits. And with less generous to lockdown assumptions, it is more like 20 or more times more costly.
I wanted to push you on that. Let me see if I understand you correctly. When governments implement lockdowns, there are going to be recessions. When there are recessions, there there is less spending on government programs like education, on roads, on healthcare, and this lessens the expected well-bees of a population.
The
Does that sound
expected
right?
well-be's, yeah, and life expectancy.
Got you. So, so as I understand it, during recessions, governments spend more money in an attempt to stimulate the economy to return back to normal. And if that's the case, then wouldn't well-bees also go up with government expenditures going up, and and thus making the expected, thus making the side against lockdowns, the argument against
Right.
lockdowns, weaker?
Yeah.
If that
Yeah.
makes sense.
Well, okay, there are 2 points to keep in mind with that. One is you are correct in the short term. Often in a recession, government spending goes up, and that prevents the loss in well-being and life expectancy. but that is in the short term. And in long-term studies, meaning over years and a decade or more, consistently the effect is different, and it reduces well-being and life expectancy. So you're right. The paradox is in the short term, that does not happen. And in fact, even in Canada, with CERB and different interventions, that's been protecting the public, and that is uh, uh, partly, I think, why people have gone along with lockdowns so easily. Um, but we have to think about the long term, and the government deficit and the loss in GDP are going to affect long-term spending, and that's where that comes into the cost-benefit analysis. And I think in the cost-benefit analysis, I assume that loss in GDP would be 5 to 6%, and I think that's a generous assumption, because it likely will be higher as lockdowns continue for a longer period. Now, other things that were not considered in the cost-benefit analysis um, can also uh, uh, mitigate that concern about short-term versus long-term, and that is that um, loneliness and unemployment in the cost-benefit analysis were I only considered their effect on well-being, meaning how someone rates their well-being at that time. I did not consider that they are two of the strongest risk factors for shortened life expectancy and early mortality and chronic diseases. And I didn't know this before looking into this, but uh, loneliness and unemployment in the are really important uh, risk factors for many chronic diseases and shortened lifespan. And in fact, loneliness is in the top three risk factors for, say, for cardiovascular disease. Uh, so not having, being privileged and not having experienced either, I hadn't considered the huge collateral damage from something as uh, simple as loneliness and unemployment. And saying they're simple is shows my privileged position, right? Because I haven't lost my job, and I still get to go to work, being a physician in the ICU. So, uh, and what I should say is those are immense problems that have been created by the lockdowns and will have huge effects in the future. And there are many other things not considered, even something like loss of education in children from school closures is a huge problem, because um, education, uh, losing even the few months of education that has occurred can be predicted to have lasting and profound effects on future quality of life and educational achievement and earning potential and lifespan and healthcare utilization for the children. And there have been cost-benefit analysis just focusing on education, and one in the United States suggested that the school closures will cause more years of life lost than any prevented uh, by reducing COVID infections. Uh, so there's a lot to consider that hasn't been. And um, uh, one other point is lockdowns are devastating the developing countries and putting sustainable development goals out of reach for millions of people. uh, including increasing food insecurity and poverty by millions of people. And those are uh, uh, that's collateral damage that I did not consider in the cost-benefit analysis. But uh, we're in a globalized, interconnected world, and what we do here affects people everywhere.
Right. Uh, so you also mentioned and discussed in section 2.5 Sweden and its reputation for being a failed herd immune strategy. But then you compared it with other countries and it looked like they're not doing as bad as everyone thought. How should citizens be judging their governments? I guess that's not very related to the Sweden question, but how should citizens be judging their governments if not by COVID case numbers and death numbers?
Well, I think the focus on case counts is misguided. Uh, uh, the focus should be on protecting those at higher risk so that the death counts are far lower. And if we had adequately protected long-term care homes, uh, over 70% of the deaths may not have occurred. Because Canada is actually has the highest rate of deaths in long-term care homes compared to other OECD countries. So I think the focus should be on preventing deaths in the high-risk groups, and also on continuity of other critical infrastructure, and that includes healthcare, um, meaning continued ability to look after all the other healthcare needs that are outside of being caused from SARS coronavirus 2. In fact, if we look back at the uh, 2014 Alberta pandemic response plan, there were four um, goals. And one was obviously controlling the spread of infection and reducing illness and death from the virus. Uh, but the other three are equally important, and that's mitigating societal disruption by ensuring continuity and recovery of critical services, minimizing adverse economic impact, and supporting an efficient and effective use of resources. And that comes to, there are four critical functions of emergency management, and that is mitigation, preparedness, response, and recovery. And um, I think the pandemic response plan and those critical functions suggest that how we should measure the response is, have we been able to separate uh, the targets from the potential threat? That's mitigation, and that means protecting long-term care homes and uh, voluntarily other older individuals, especially with comorbidities. Uh, and preparedness fits with ensuring critical services by building surge capacity to effectively and rapidly respond when people at risk are affected by the hazard, that is the virus. Uh, and recovery is a bit of a misnomer because it should occur at the same time as all the other factors. So it's concurrent, not at the so-called end of a pandemic. And that is to reestablish the economy in a normal state of life. And that's what the other two Alberta response plans focused on, and that's minimizing adverse economic impact and recovering from that. So, I, so I'm kind of thinking out loud here. I think what we should focus on is, have we been able to protect the high-risk groups, and that so that deaths from COVID uh, numbers are far lower? Have we been able to uh, have a plan and enact it if necessary for surge capacities in hospitals so that we can continue with the critical services of healthcare that have been shut down? And have we been able to keep society functioning so that there is not an economic recession? Um, and those are, I think, metrics that would uh, be better than focusing on case counts, because case counts give us a raw number with no context and no denominators, meaning, uh, you know, we're not good with big numbers, humans, I mean. We're not very good at being able to comprehend large numbers. And it was very surprising to me that when I looked into it, that, like I say, in Canada, in so-called regular or non-pandemic years, there are over 797 deaths a day. And that's a huge number. And that's a tragedy every day. But we need, I think, to put the COVID numbers in context um, and focus on who's really at high risk, and not try to scare everybody. I think the fear is out of proportion to the risk for most people.
Mm. Yeah, it's different to say there are 500 new cases of COVID in this city or in this province versus 30 people went to the hospital across the province. Um,
And,
yeah.
and if that number went to hospital, what proportion of hospitalized patients are with COVID, right? If it's, is it 5%? Is it 10%? Is it 100%? It wasn't 100%. Um, it uh,
4 to 6%.
something like that, yeah.
Um, I'm surprised by how non-transparent the government has been with their response to this pandemic and to the number of hospital beds available and all of that. It's I hope that changes. But my last question was, have you received any pushback from any of your colleagues for advocating against lockdowns? And how have you responded to that, if so?
Uh, well, uh, because we are asked to mostly work from home, I probably have not had as much pushback as I would have if everyone was always at work in person. So that may be one good thing. No, you know what? I'm a bit frustrated because there's this uh, so-called Edmonton Zone Pandemic Committee, Strategic Pandemic Committee, uh, that is part of the Edmonton Zone Medical Staff Association. And they had a big piece in the Edmonton Journal with questions and answers. And David Redman and I wrote a commentary, an opinion piece about that, where we pointed out some of the other information that was missing and what we suggest. And the committee responded in the paper with an opinion piece, but that opinion piece was full of misrepresentations of our view and misleading statements. So, that paints our view in a poor light by misrepresenting it, right? The so-called straw man arguments and ad hominem arguments. And what I wish is that people would stick to the evidence and use the evidence to come up with the best response. And I've said with David Redman what we think is the best response, and the reply to that, I don't think addressed any of our arguments because it was had many misleading or misrepresentation statements. So I guess what I'm saying is yes, that is a bit of an attack on me on me in terms of the debate, but you know what? That's okay. I can take that. I just it makes it difficult because uh, uh, being able to respond in the to those misleading statements is not something that will get to the public. And that's why I agreed to do this kind of interview.
Right. So the response, so the way that you respond to ad hominems and mischaracterizations is to try and speak a bit louder than your opponents and to get your truthful message out as accurately as
Uh,
possible.
yeah, I don't know about louder. I think uh, trying to uh, clarify misunderstandings and make sure the evidence that I'm giving is as up to date and as clear as possible, so that any it may be that somebody comes up with a critique of what I've been saying that I look at and go, I hadn't considered that, and that's a good point, and it might change my opinion, just like my opinion changed from lockdowns to saying they look to be far more harmful than beneficial. I don't think that will happen because I haven't seen that in any of the responses or questions when I give talks to what I've been saying. Um, but I'm open to, respectful academic debate, and I try to stick to the evidence that I've seen and that's in the literature, and let people decide based on that instead of trying to, misrepresent what others are saying.
Okay. We'll leave it at that then. Thank you,
Thank
Dr.
you so
Joffe.
much.